you, Mr. Chairman. Welcome, Madam Secretary.
Yes.
I don't envy you the challenge you have before you. All of us face the same thing, but you're in a very special hot seat. In general, I'd like to talk about medical errors a bit and a bit about Medicare, but before getting to that, as we've gone through this debate over the last year, it's become very apparent to any observer who's looked closely that the key players on the majority side, the President, the Speaker's closest advisor, Mr. Miller of Oakland, indeed Henry Waxman, have been supportive of a single payor system. Now, I know that's not the bill that we produced, but it lays the foundation for exchanges to become a lot more than state-based, but rather federal-dominated. And it concerns me an awful lot that we ignore that. Would you respond to you and your office's view of a single payor system at the federal level?
Certainly, Congressman, I'd be glad to. I think from the outset of this discussion, there were certainly those in the House and the Senate who favored a single payer system and felt that that was by far the preferable option. From the beginning, the President made it very clear that he did not, in spite of the fact that he had in years in the legislature and even when he came to the United States Senate, talked about that as an option that would be ideal. The more he looked at the situation with 180 million Americans having insurance coverage that was preferable to them and that they felt that what we needed to do was build on the current system. And that's really the structure that the bill took from the outset, in spite of, I think, the disappointment of some in the caucuses who would have preferred to really dismantle the third-party payer system. So that this really starts at the states. States put together exchanges either as a single state or in a multi-state area if that's what they choose. We provide technical assistance to the states to do that, and even though the exchanges are not the timetable for exchanges doesn't begin until 2014. Right. We intend, starting next year, to begin very robust discussions so that we don't wait till the last minute and have states in a situation where they can't do this. There are, we have already had lots of positive discussions, and states are very eager to do this. And I think it will very much be a state-based program, and particularly, Congressman, it is not to dismantle what's in place right now. It's really to replace the market for self-employed Americans, many of whom cannot find affordable coverage, don't have any leverage, a lot of small business owners who find themselves in the same situation.
If I could take you to medical errors.
Yes.
You suggest that within the department you want to at least model some evaluation of medical errors to see how we can improve on that pattern within the health care delivery system. Might I suggest that one of the major federal medical health care delivery systems lies within our military? There is plenty of evidence that there is rampant across this system an error-based system of delivery. I would suggest that you might start there and help us with you to evaluate what's going on in that medical health care delivery system that supposedly is serving the most important servants we have in our society, the men and women who fought for this country. Huge problem there. I'd be interested in your reaction.
I'm sorry. I want to understand what you're saying, Congressman. We've begun certainly discussions with not only the VA but the Department of Defense on their system. You're suggesting that there's a rampant medical errors within the healthcare system for.
There's evidence at the highest levels that system deliveries are, at best, produce an awful lot more errors than the norm, and we might start that examination right there.
Well, I think that's a good point, and I will follow up on that. Thank you.
One of the President's major promises was that if you like your health care, you can keep it. And yet, to pay for the new health care plan, the law, it appears, would cut in a major way Medicare Advantage by some more than $130 billion. I have 50,000 plus seniors in my district who enjoy Medicare, and indeed they're concerned about what these proposed cuts might do to that service and existing delivery. What can my seniors expect relative to implementing this program?
Well, I think that there is a provision, as you know, as part of the law, that over a decade, a portion of the overpayment to the Medicare Advantage plans will gradually be phased out. There are about 400 plans, 400 companies right now offering about 1,100 plans throughout the country, about 11.5 million seniors taking advantage of those plans. We have just actually put out the 2011 Medicare Advantage updates, which will have the same rate payments for 2011 as they did for 2010, and noticed plans across the country. There will be a robust array of choices for Medicare recipients, as there are right now. I don't think there's any question that we are going to begin to pay more attention and collect more data, and the CMS on medical outcomes for looking at not only the fee-for-service side of Medicare, but also the Medicare Advantage side of Medicare, to make sure that if enhanced payments are going out the door, it's really for a higher quality health outcome. And we know bundled care produces that, medical home models produces that, and there are a number of Medicare Advantage plans who are very eager to engage in that. But I think that the misinformation to seniors about the fact that Medicare Advantage is somehow not going to be a choice is just wrong. We anticipate that there will be no shortage of choices of Medicare Advantage plans throughout the country.
Thank you, Mr. Chairman. I must say, Mr. Chairman, that what she just mentioned is a major stumbling block, but if I were going to point to the greatest stumbling block, it's when the average family, let's say 25 to 45, suddenly finds a mandate with the IRS looking over their shoulder that they must start putting money into a pool for some future service delivery.